Great. So this is John Day from Stanford University. It's my pleasure to talk with you all today about aspects of managing Charcot-Marie-Tooth and the consequences of having CMT. This is obviously a very exciting time for us in the CMT community, and we'll talk more in this conference about some of the upcoming treatments, but a critical aspect is starting those treatments when you're at optimal function and also continuing to maintain optimal function even on the treatment. So the treatments aren't magic. They're very effective, but we need to continue to manage appropriately. So let me see if I can share my slides. So I hope you're seeing my slides now. So this is about CMT management. How do we optimize health and function while waiting for genetic correction? So I did want to acknowledge that I do work with many companies that are working in this space, and also to point out that it really takes a team. So this is our Stanford Comprehensive Neuromuscular Team, but this isn't all done by any one individual. So it takes neurologists, physiatrists, physical therapists, occupational therapists. You'll hear later from the genetic counselor as part of our team. Obviously, we have consultants in many subspecialties to help us and help patients with CMT to function optimally. So it really is a team effort. It's been our pleasure at Stanford to be involved in the development of treatments for a different type of nerve degeneration called spinal muscular atrophy. It could have been named a type of CMT, but it's so severe it got a separate name. And we can say that these treatments are phenomenally effective. But as I already pointed out, they're not magic. This isn't a Hogwarts spell that is going to make all elements of CMT disappear. And so we really do need to understand what we're dealing with CMT. And I wanted to cover a number of aspects. So we'll talk about CMT in general, because I know there's some people new to the community, and I wanted to make sure we were all on the same page. A lot of the elements of care, though, are preserving nerve function, preserving joint function, optimizing neuromuscular function and stamina, so strength and stamina, and then minimizing pain and discomfort. And I'll try to talk about all elements of that during this upcoming time. If you have questions, please add them in the Q&A, and we'll see if we can get to some of them at the end of the talk. So first, I wanted to talk about what peripheral nerves are. Peripheral nerves are obviously the part of the nervous system that goes from the spinal cord out to the limbs. So out to muscle, but also out to skin, so that it provides sensation and it controls the musculature. All of the cell bodies for those nerves are actually up in or nearby the spinal cord, so that all of the cell bodies are very, very central. But the axon, the nerve fiber, goes all the way down the limb to the muscle or to the skin to provide the function that's required. So that's a long way from the cell body. The cell bodies are all very near the spinal cord, or actually within the spinal cord. So that's what nerves are, and that's what are affected in CMT. So nerves are basically the electric wires of the body. They carry signals down, and if we record from those nerves, we can actually see that electricity. We can measure it. And if we stimulate the nerves, and many of you have had this, it's not a pleasant test, but it gives us very important information. So the nerve conduction study, we stimulate the nerve, and then we can actually see that response. So we get a very organized, specific response from that nerve as it travels down the wire, the nerve of the patient. what we can calculate from that is the velocity. We can see the size of the signal. It tells us how well that nerve is functioning. Now, each of those nerves is actually an amazing amalgamation of these various proteins. It's an amazing structure. It's absolutely gorgeous in its construction. And they're electrically active channels that keep the electricity flowing. It's not as simple as a wire. It's much more complex than that because the body has to come up with a number of different elements to make it function like an electric wire. But here's that wire again. So this is the cell body on the left, and it sends that signal all the way down to the end. But all along that course, it's constructed just like that element that I showed you at the bottom. So it's just this repetition of these channels and structures all along the way. This blue up here is representing the insulation of the nerve, or the myelin, so that the blue or myelin keeps the electricity from leaking out. It keeps it within its space so that you have the cell of the nerve carrying the electricity down, but you also have these different cells constructing the myelin or the insulation along them. So these are called Schwann cells in the peripheral nervous system, and they're very, very important to make sure the nerve works. And this demonstrates what a nerve actually looks like. So in cross section, so each of the nerves functions as a wire, and each of these little donuts in the middle. So this whole cable, this is one small nerve going along the ankle, and you can see within that one small nerve, there are hundreds or thousands of individual nerve fibers. So each of these little donuts is a single cell. But it's long and stretched out, and the darkness here is the myelin. So what we're seeing is the myelin, and the axon, or the nerve fiber, is within the center part of that donut. And so that's the way a normal nerve should look. It has lots and lots of these individual fibers, all contained within the cable of a named nerve. Now, that myelin ends up being important to keep the electricity in, and what we can see is that it is responsible for the nerve sending a signal much more quickly. So with a myelinated nerve fiber, that signal gets down to its end very fast. It might be going 50 meters per second or something like that. It's quite fast. But if the myelin is absent, and there are many nerves that don't have myelin, so it's not mandatory that a nerve have myelin. There are many unmyelinated nerves. Those will send their signals much more slowly. And so that's the normal configuration, as we'll see nerves that contain both myelinated and unmyelinated fibers within them. Now, if the myelin is damaged, and this comes up in a type of CMT, the signal goes from being very fast. When the myelin is damaged, the signal goes much more slowly. So if the signal gets down at all, there's very little loss of function in that, but the signal is actually transported in a much more delayed manner to get down there. So rather than going 50 meters per second, it might go 30 or 20 meters per second, which takes several milliseconds longer, hundreds of milliseconds longer to get down to your feet. But as you might imagine, that's not going to be associated with any significant functional change as long as the signal gets there. So there is going to be a loss of speed, but not so much a loss of function otherwise. So what ends up happening is that the nerves in combination will send their signals more slowly, so that, again, remember, that's a cable of those different fibers. And if all of those myelin sheaths that are insulating each nerve are damaged or thin, then the signal will transmit much more slowly. And in composite, you'll get the signal there, but you won't get it as quickly. So again, not so much of a functional change, but definitely a measurable change. But if those nerve fibers are damaged, or if the myelin is completely stripped off so that the nerves just can't send the signal, it all leaks out, then you not only have slow fibers, but you have a loss of the signal. So if you lose the signal amplitude goes down. That's associated with a loss of function. So it's that loss of function that is associated with the symptoms of CMT, whether that's a loss of ability to feel, whether it's a loss of ability to move, one way or the other. The loss of of the nerve function overall is what's important clinically. So that's what we're trying to abate or mitigate, is to ultimately reduce the number of nerves that are dysfunctional, but also to maintain the elements of function, or to develop ways of working around the consequences of the loss of function of those nerves. So that's the game when we're trying to manage symptoms of CMT, that we're trying to help people deal with the loss of function of nerves, as well as trying to prevent any unnecessary loss of nerve function. This comes up in the motor nerves as well, and I wanted to show this here, but we'll talk about it a little bit more when we start talking about exercise and stamina, because I think this kind of gives you a picture. If we activate a nerve going to a muscle, we can activate it a little bit, in which case we'll get just the muscle fibers responding from the nerve fibers that have been activated. But if we increase the size of the stimulus, we activate more of the nerve fibers. That activates more of the muscle. And so each time we increase the stimulus, we activate more nerves, we activate more muscle fibers, and we get a bigger response, until finally you're activating the entire nerve and you're getting the entire muscle to respond. So that this gives you, again, a sense of that graded response. And you can imagine this happens in reverse. If you start losing nerve function, you start losing muscle function. So if you lose some nerve fibers, the muscles that are connected to those nerve fibers, the muscle fibers connected to those nerve fibers stop functioning as well. And we'll talk about that a little bit more when we get into the aspects of exercise that I wanted to cover. Okay, so just to allude to the genetics of this, and this will come up on other talks during the conference, and it'll be a high point of what we talk about when we talk about new therapeutics. It's important to realize what we're talking about, so that in terms of genetics of peripheral nerves, we talk about the DNA, and the DNA is the same in every cell in the body. So it's in the same in every one of those Schwann cells that's created some of the myelin along the course of a nerve. So that's a lot of Schwann cells for a lot of different nerve fibers. Each nerve fiber within that cable has its own Schwann cells, and each nerve fiber along its length has many, many Schwann cells. So there are many, many Schwann cells, each of which has the DNA that's identical in every cell of the body. But each nerve cell also has that same DNA. So the DNA that's altered in CMT can either alter the function of the nerve, or it can alter the function of the Schwann cell, and by doing that, alter the function of the nerve fiber. So it can either way will alter the function of the nerve fiber. Now, the DNA is constructed in different genes. The genes are constructed in different elements. So the genes are little pieces that have to be stitched together. And that stitching together allows them to generate a signal, and the signal generates a protein, and the protein is typically what's altered in CMT. Maybe it'll be lost, maybe there will be too much of it, or maybe it'll be altered in some other way. But oftentimes it's a protein that is altered because of a genetic change in a gene that's either in the Schwann cell or in the nerve fiber. that leads to the dysfunction of the nerve fiber that leads to the weakness or the sensory changes that we see in CMT. So hopefully you get a sense of this scale of how this all adds up. And then we'll talk about how this alters function in CMT. But I did want to just show you a little bit more of what we're talking about. And this will be covered, I know, by Carly in her upcoming talk on genetics, but it'll also be covered by others, the different types of CMT, how we alter genes in different ways. And then this is just a list, just to make this even more kind of mind-numbing, is all of the different genes that can be affected. So each form of CMT alters its own specific gene, and that then ends up all having the common elements that we talk about in terms of management, because we talk about the changes in the overall function of the nerve fibers in a very similar way from one type of CMT to another. So the treatments have to be very specific to the actual genetic change, but management ends up being very similar from one type of CMT to another. So again, there's our normal nerve with the amount of myelin around each of those individual fibers. This is a nerve that has a form of CMT. This is a type of demyelinating form of CMT, and you can see these very thinly myelinated nerves. So these are nerve fibers that have too little myelin, and then there's also a loss of nerve fibers altogether. It doesn't have that jam-packed appearance that previous slide did. Here you can see there are lots of nerve fibers. Here there are many fewer, and there's some other evidence of nerve damage here, but there's a primary deficit in the amount of myelin around each of these individual axons or nerve fibers. And so this is a demyelinating form of CMT. This is from a nerve of a patient who had a primary axonal form of CMT. And you can see that there are just way too few of these nerve fibers compared to that normal nerve I showed you before that was jam-packed. Here there are many fewer, but the ones that are remaining have a pretty normal investiture of myelin. So this myelin cover looks pretty much normal. So this is what we would call an axonal form of CMT. This is due to a gene that's altering the function of the nerve fiber, nerve cell itself, not so much altering the function of the individual Schwann cells. So that's what we're dealing with. All forms of CMT have common elements of weakness and altered sensation that we're going to really work at optimizing management of, but the causes can be quite varied in different genes affecting the different cell types. Okay, so that's what I wanted to talk about first, just so we all kind of had a level playing field in terms of what CMT is. And now we're going to talk about the elements of management. And I've broken that into these different parts of preserving nerve function, preserving joint function, minimizing pain and discomfort, and optimizing strength and stamina. And we'll talk about those in sequence here. So preserving nerve function. What do we need to do to preserve nerve function? Well, we need to prevent additional damage. So ultimately, we'll come up with a treatment for CMT that's going to get to that underlying genetic cause. But in the interim, we have to keep those nerves as pristine as possible by avoiding any additional damage. And that's important. This is really, really important, because having CMT not only causes damage to the nerve fibers themselves, but it predisposes to additional damage. So many of you have heard of carpal tunnel syndrome. We'll talk about that. That's a nerve damage due to compression of the median nerve at the wrist. Having CMT probably increases the likelihood that you could suffer from that, because your nerve is already somewhat more fragile, more delicate, and thus you could get a compression. So one of the things we talk about oftentimes in clinic is whether or not you have any episodic symptoms. And so this is an important issue. There are many different ways that nerves can be damaged. People without CMT suffer nerve damage. And so how can you tell if you have something in addition to CMT? And there's several different features that come to mind, but it's important again to realize the importance of dealing with these things, because the nerve cells again are all up in this around the spine, but the nerves themselves are very, very long. They're very uh, uh, commonly affected by anything that can damage nerves, and so we have to be thinking along those lines. The longer the nerve is, the more likely it is to be affected. That's a truism with regard to CMT itself, but it's also a truism for any secondary nerve injury that we're going to be talking about. So the longer the nerve is, the more likely it is to be affected. So that's why symptoms typically start in the toes and then go to the feet and the legs, and the nerves down to the fingers and hands are about as long as the nerves going to the upper part of the leg or around the knee. And so that, since they're about of the same length, they're going to be affected about the same time. So, you know, neuropathies tend to start in the toes and gradually ascend, and then start to affect the fingers and start to ascend. And there are obviously some exceptions to these rules, but that's a pretty common rule. So, what are the signs that there is something else going on besides CMT or in addition to CMT? These are some of the triggers that we'll ask about. So, has there been any change in the rate of progression? You get some awareness of what the CMT changes will be over time. Did that change, or did you get episodic or symptoms where your hand started tingling and then it stopped, or your foot started tingling and then it stopped? Or were things triggered by different events? My hand always tingles whenever I'm talking on the phone or whenever I'm typing on the keyboard. That's a sign that there's a secondary nerve involvement. So other triggers that make us think about this would be a change in distribution. If you had symptoms that were predominantly in your feet and then all of a sudden your left hand went numb, that would be atypical of CMT, and it would make us wonder about whether or not there was something in addition, something superimposed on it because maybe of the increased sensitivity of the nerves due to having CMT. So is it typically symmetric, or did it all of a sudden become asymmetric? Just one hand was affected, or changes in the type of pain. We'll talk more about that later. And then this non-length dependent, so that if things all of a sudden you've got numbness in your face, whereas you had numbness starting out principally in your feet, that would be a sign that maybe there was something else that was triggering that. So these are some of the triggers that will get us in our talking with individuals with CMT to think about whether or not there's a secondary process, because those are the things we think we can control better. We will be able to control CMT, but we certainly have to always control these so-called acquired causes of neuropathy as well. And so what are some of those? Well, there are many, many, many of them, and I can't obviously cover them all in this talk. You've all heard about diabetes and how diabetes can affect nerves, and that's absolutely true. If you have CMT and then you get diabetes, you are much more likely to have nerve problems. So it's that combination that can be problematic, and that's true for exposure to some specific anti-cancer drugs. Not all anti-cancer drugs, but some of them can also damage nerves. Certain vitamin deficiencies can damage nerves. And if you have CMT and you have any of those things happening, that needs to be addressed. So much of our management of CMT focuses on avoiding or minimizing the possible exposure to other things that are going to damage nerves, such as this list. And then at the bottom, I've listed the importance of compression. So obviously we use splints and braces for some CMT patients, but they have to really fit well, or you run the risk that the braces themselves could be damaging the nerves due to compression. So walkers can damage nerves in your hands. Crutches can damage nerves in the upper part of your arm. There are different compression sites for a lot of nerves, and we need to really be careful in doing things well because the nerves in CMT are more sensitive to this kind of compression and entrapment. So those are some important issues about maintaining nerve function. And this is just a list. I don't want to put too much emphasis on specifics. Every nerve in the body can be compressed in different ways. So it's more those early symptoms that I was talking about focal issues that we need to use to tell us if a nerve is being compressed. And this just shows one of the nerves, the ulnar nerves, and all the different possible sites of compression that can cause superimposed nerve function, and we need to take these all very seriously. Now, it's got the world has shifted in one way because we've got these new methods of assessing nerves. It used to be very hard for us just using nerve conduction studies alone, just the electrical testing, to tell whether or not someone with CMT might also have nerve compression at the wrist or nerve compression at the elbow. We're doing a better job of this, but it's an area that we're focusing on a lot and using ultrasound. So ultrasound allows us to actually visualize the nerve, and a lot of the centers, CMT centers, are now employing this so that we can look and see whether or not a nerve is showing signs of compression in addition to having the altered function just due to the CMT itself. So teasing those things apart can be difficult. It can still be difficult, but use of ultrasound has really revolutionized our ability to look at this. And so that's an exciting development. And again, we'll continue advancing these issues even as we move into the genetic treatments, because management of CMT is going to continue to be important even in that era. Okay, so that's preserving nerve function, looking at those secondary causes. We also have to focus on preserving joint function, and this is obviously critical, and many of you have obviously dealt with this. And it comes down to, again, what can we do? It's about positioning the limbs and joints appropriately, supporting them appropriately, and maintaining flexibility. So just a few slides on this to make it a little more clear of what we're talking about. We talked before about how the longer the nerve is, the more likely it is to be affected. Well, what that translates into is that the muscles in the foot are going to be, the nerves to those muscles are going to be damaged much earlier than the nerves to the muscles in the lower part of the leg. And so that's the way this works, is that in CMT you lose function of the so-called intrinsic foot musculature long before you lose a function of the muscles in the leg. Well, that leads to some imbalance, so that when you lift up your foot and lift up your toes, you're using ideally these intrinsic foot muscles that are helping pull those toes up, so that then when these leg muscles come down, they insert on those same bones in the toes and lift them up. But if you've lost these lower nerves, the nerves in the foot, then the upper nerves are working in a less ideal way. The toes aren't going to be aligned appropriately, and the long muscles coming down from the leg are going to distort the position of the toes. And this leads to many changes, as does the loss of the flexors. So that, again, you have these intrinsic foot muscles, both the muscles that curl the toes and the muscles that straighten the toes in the feet can be damaged or not functioning as well because the nerves have been lost to those muscles. And that alters the positioning of the toes and the feet when the long muscles from the leg come down to move the toes and the feet. And that leads to these altered positions of the toes, so that this is where the so-called hammer toes or claw toes develop. It's because those long muscle fibers are still working because the nerves to them are strong, but the short muscles in the foot have stopped working. And so that causes this distortion of position and leads to altered positioning of the toes. And so that leads to these changes. That leads to either having an over arch, a higher than normal arch, or if you lose function in the leg muscles coincident with the loss of foot muscles, you can end up with a flat arch. So that either can occur in forms of CMT, but they're due to these imbalances between the long extensors and flexors coming down from the legs, as opposed to the intrinsic extensors and flexors that are lost earlier on in the feet. And so you can easily imagine how this is going to alter joint function, both at the ankles, but also at the knees, the hips, and even up into the spine, because these feet are functioning differently. And this just demonstrates that, so that we will commonly see loss of muscle in the feet and in the lower legs before loss of muscle in the upper legs and thighs. And so it's a very common situation. And even if, as the neuropathy progresses, then we'll be left with the consequences of those early changes if the feet have been distorted in terms of their construction and configuration and the way they work. The same kind of thing goes on in the hands, but because you're not weight bearing in the hands, the implications of these are different, but the same kinds of things will cause distortions of the way the hands work. So we do have to be conscious of how we're supporting the hands. Again, it comes down to that positioning and support so that we can optimize function. It doesn't take a lot of imagination to understand that by having an altered position of this ankle, that is going to really increase the wear and tear on the ankle. And it's probably not that hard to imagine that that's also going to cause wear and tear in the knee. And so this abnormal positioning of the foot ends up being really important orthopedically, because we want to avoid damage to those joints. And it's not surprising, even looking at these feet, that this tight heel cord here is going to prevent, as this person walks, it's going to prevent bending of that ankle. The ankle will not be able to bend when walking. And what that does is it transfers increasing force to the front part of this foot that now has to bend to accommodate the ability to walk. And it puts much more pressure on the foot. So these are the changes that we need to be conscious of when we're helping people deal with the consequences of CMT. We want them to be able to walk. Obviously, we want everything to continue to work well, but we want it to minimize the amount of joint damage. And so this is where we will, increase stretching, increase the use of orthotics to support the ankle and to support the foot, so that we're not causing as much joint damage. So various elements go into this, and obviously there's a talk coming up on splinting and bracing, and that's why this is such an important part of the management of CMT. Okay, minimizing pain and discomfort. I'm going to go through this a little more quickly, so we hopefully have a little bit of time for questions. But this is obviously an important issue. To talk about pain, this is more words than you can possibly read, but it reminds me to just point out that the nervous system is involved in all elements of pain. So that if you break your bone, the nervous system is what reports the pain of that broken bone to your brain so that you understand that you have something wrong. So that's so-called neuroceptive pain. That's where the nerves are just working as the reporters. But if you damage the nerves, classically you hear about this on commercials, for diabetic neuropathy, the damaged nerves can themselves send out increased signals that are experienced as pain. And so the nerve can be either involved in that neuropathic pain or neuroceptive pain. Both occur in CMT. Commonly, the neuroceptive pain occurs because you're getting that tissue damage or joint problems. So you get an aching kind of pain, as opposed to the other type of pain. If the nerves themselves are the cause of the pain, that'll be typically a more jabbing or burning type of pain. So there are different kinds of pain and there are different ways of dealing with it. So again, managing CMT, we want to minimize pain. How do we do that? Well, we try to preserve nerve function, as we already talked about. Diabetic neuropathy much more commonly causes neuropathic pain. So if we can minimize any kind of additional nerve damage, we're going to be limiting the neuropathic pain component that patients with CMT have. But joint damage it also occurs in CMT. So if we can minimize joint damage, we're going to be minimizing the neuroceptive pain, the kind of aching pain that is common in CMT. So all of these are issues. And this I already talked about. Just to make the point, in nerves, there are two different types of nerve pain fibers, these so-called thinly myelinated fibers. These are A delta fibers, and the unmyelinated fibers, the C fibers. These are both pain nerves. These big sensory fibers, the A alpha fibers, carry sensations like vibration and things like that. Those are not pain nerves. But you can imagine now if you have a demyelinating form of CMT, that could affect the A delta fibers, but it would not affect the C fibers. And so, these, at least not directly. And so these are the issues that come up for CMT. And I'm going to scoot through some of these other slides just to uh, point these out to people that are interested. But those different fibers actually go into the nervous system and pathways in different ways. And so are really processed quite differently. And the A delta and C fibers also give you two different types of pain, so that if you prick yourself with a needle, you feel that pain in a very well localized way and very acutely. So that's that A delta fiber type of pain. But the C fiber pain is unmyelinated. It's going to go more slowly. So this is the kind of pain where if you hit yourself with a hammer, uh, you get an immediate pain. That's the A delta first pain. But you have even time to just sit there and wait for it. You go, oh, this is going to hurt. And then that next pain comes on, and it's kind of a nauseating, kind of less well localized, maybe throbbing, kind of gut wrenching pain that comes on in a second way. That's actually got a different physiology. That's actually the C fibers that are conveying that type of pain. And both types, involve the nervous system. But this kind of leads to why you can have such varied consequences of pain in CMT. You have different nerves being affected differently by different forms of CMT and by any of the superimposed secondary neuropathies that also come on. Different stimuli will activate pain fibers. So again, the differences here, pain fibers will actually be stimulated by tissue breakdown in different ways, and they interact so that this is the way that non-pain fibers can actually suppress pain fibers. It's a very, very complex system that leads to a number of different approaches that we take to mitigating pain when patients with CMT have pain. So that lots of different types of pain, lots of underlying neurophysiology, and lots of different mechanisms that we can use to try to deal with pain. The nerve fibers themselves can cause the pain, as I mentioned. If they're damaged, they'll start just signaling on their own, and that causes that neuropathic type of pain. And this is just another demonstration of that. So pain is a constant issue for CMT, but there are these additional pain cycles that I at least wanted to mention. So pain can be caused by muscle spasm, but muscle spasm can also activate nerve fibers that cause more muscle spasm, so that you get this cycle of muscle spasm causing pain and the pain causing muscle spasm. Similarly, you can get the so-called sympathetically maintained pains where the autonomic nervous system, I didn't talk about that, but that causes some altered function of blood vessels and things like that that can themselves be painful. And then that can stimulate more autonomic response. So again, it's a pain cycle. And then inflammation. So it's not always appreciated that pain actually causes inflammation. So activation of pain nerves releases chemicals that causes inflammation, but inflammation, it's not surprising, also causes pain. So pain causing inflammation and inflammation causing pain is another one of these cycles that gets set up that we need to sometimes break. So again, we have lots of different thoughts going on when we're dealing with pain in CMT, and there's an awful lot that we need to try to tease apart to manage that optimally. So this just is a cartoon showing how muscle spasm can cause pain that can re-trigger the muscle spasm, and you can set up these cycles. And similarly with sympathetically maintained pain, and similarly with neurogenic inflammation, where the nerve cells actually cause the inflammation that further stimulates the nerve cells. So these are complex issues, and oftentimes we need to need help from the pain specialists to deal with a lot of these things. But this is why, we'll oftentimes spend a lot of time talking about pain when we see patients with CMT back in the clinic. Okay, so how are we dealing with, avoiding primary and secondary pain? We're trying to maintain, again, do everything we've already talked about. We're maintaining a proper position and joint alignment and flexibility. We're trying to not overuse strong muscles. We're trying not to overtax weak muscles. We're maintaining conditioning and range of motion and avoiding any secondary nerve injuries. Just a word about temperature. Oftentimes people with CMT have very cold feet. That's in part just a normal physiologic reaction. If your musculature is thin, if you don't have much muscle in a limb, the body just decides you don't need as much blood flow there. And so it's very common to have cold feet, but that can be quite uncomfortable. So if the cold feet are bothersome, then you need to increase that blood flow. And one of the ways to do that is to try to get your core temperature up. If you get your core temperature up by wearing a sweater or putting a hat on, then that will increase the need of the body to circulate more blood to the periphery to get your core temperature lower. And that circulating more blood to the periphery will actually warm your feet and hands up. So don't just treat cold feet with socks, but actually, wear sweaters or keep your core temperature up to improve the blood flow to your feet. It's not typically due to anything wrong with the blood vessels. It's not a vascular problem. It really is simply just due to the fact that they don't have many muscles there. So a lot of issues coming up with pain management, and those are things I wanted to talk about. And then just a word about optimizing strength and stamina. This comes back to several issues that we've already talked about maintaining flexibility of the joints, but we also want to focus on not over exercising weak muscles. And I'll go into that a little bit more. This is where working with really skilled occupational and physical therapists gets to be so important, because we don't want to over exercise the weak muscles, but we want to be able to fully exercise the strong muscles. And again, typically the strong muscles are going to be those in the hips and the thighs, or the shoulders and the arms, while the weak muscles are going to be those at the wrists and the hands and the feet and the lower leg. And so we need to come up with exercise that allows good exercise of the strong muscles, but not over exercise of the weak muscles. And again, there are things that can be done in water that we just can't do otherwise. And I could give a whole hour-long talk on the value of water-based therapies, but obviously there are challenges in water-based therapies as well. So those are the issues in terms of exercise. So causes of fatigue, this is due to a combination of things: motor neuron overactivity, neuromuscular junction. So the signaling from the nerve to the muscle gets taxed. And then we actually get myopathic changes. And I just came up with a cartoon to try to demonstrate this. So each nerve goes to many muscle fibers and activates those muscle fibers. So each of the different nerves going to the particular nerve will activate different muscle fibers, but in combination, then you can activate the entire muscle. So that's the way a muscle is meant to work. If you lose one of the nerves, then those muscle fibers that it controlled are no longer active, and to get them to work, one of the surviving nerves will branch out and go to those muscle fibers, and now you have full strength again. So you're activating the entire muscle, but one of the nerves is working overtime to do it. So that's going to cause more fatigue. Furthermore, it might not work quite as well. Things might be a little bit out of sync because one nerve is doing a much greater amount of the work, and as a consequence, fatigue enters into the equation. You might have normal strength, but you really run out of gas much more quickly, and that's part of the reason. Now, as the nerve damage progresses and you lose more nerves, eventually you get to a place where the muscle fibers can no longer be reinnervated, so that you've lost the capacity of the nerves to do as much. So now you have muscle fibers that are no longer contributing. Now you have weakness. So that really ends up being a persistently weak muscle, but still a very fatigable muscle. So stamina is a big issue in even strong muscles, because nerves are doing more than they were originally meant to do. But it's certainly an issue in weak muscles, and we just have to take that into consideration. So those are the issues. There are ways of dealing with it, and I've kind of run out of time, so I need to wrap it up. But I did appreciate the opportunity to go over all this with you, and I will stop at this point. So I think I've pretty much exhausted our time. I don't think we have time for Q&A, but I will leave that up to the host to tell me otherwise.
Hi, Dr. Day. Thank you for a phenomenal presentation. We are out of time. We do have a list of all the questions, though, that have not been answered, and we will be following up directly with all community members to get those answers to them. So thank you again, everyone. And if you want to head to the next session that starts at 11:25, we will see you there.